Good morning, everybody. Ladies and gentlemen, it is a great pleasure and a great honor for me to participate at this meeting at the Ethic Forum and the prestigious Galien Prize. I'm honored and happy to chair this session devoted to women's health with my friends and colleagues, Professor Laura RIENZI from Roma, Professor Rene FRYDMAN from Paris, Professor Attilio DI SPIEZIO SARDO from Napoli, and Professor Michèle from Paris. Our women's health has become more and more important with the incessant medical and biological discoveries in the last decade. Due to research, due to science, and with the increase in life expectancy, we have understood step by step the patterns of reproduction, the ovarian function, and the transient nature of this function, which must stop at an age around 50. The cessation of hormonal secretion and the reproductive function of the ovary is responsible for the symptoms and manifestations known as menopause. These changes and their consequences on women's health constitute an important part of what is known now as women's health. Science and research have also allowed us to deal with the failure of ovarian function. Fertility preservation tries to deal with this early failure of the ovary. This procedure must always be carried out with a very specific ethical aspect which should be taken into consideration. Women's health will also be concerned with the consequences of menopause and all the pathologies which occur at that time, from gynecological cancer to dermatological manifestation. Finally, medicine will try to treat all these consequences of this menopause such that the woman's health requires multidisciplinary care. In this session, we will see an example of multidisciplinarity in the management of women's health. We will start by a topic about preservation of fertility or fertility preservation with Professor Laura RIENZI. Laura, nice to meet you, and thank you very much for your coming. We are your guests today because...
Yeah, you are my guest. Welcome to Rome. It's a great pleasure to have you with the sun. It will be 37 degrees today, so go to the swimming pool later on.
Thank you for the word.
So if I can have my slides. So my first disclosure is that I am a scientist, a biologist. And I've been working all my life on this beautiful cell that you see here in the background, which is the oocyte. So this is where everything starts when an oocyte, of course, gets in contact with a sperm and create an embryo. This is my real conflict of interest, but nothing related to this presentation. Unfortunately, fertility changes with time. And unfortunately, much more in women as compared to men. Charlie Chaplin had his seventh child at 82 years old. So we know that male fertility is better preserved, although also spermatogenesis is affected by male age, especially after 50 years old. But in women, this is dramatic. It's like if nature has decided that there is a window where the women can get pregnant, when the woman can get pregnant. And so with advanced maternal age, we lose quantity because we have a defined number of oocytes from when we are born. So this is called ovarian reserve. And we lose this potential during time, but also in quality. So there is a decrease in quality. And what is really incredible is that the quality stays until 35 years old, but after 35, there is an exponential increase in what we are going to see, aneuploidies and lower competence of the oocyte. So it's like a window for us women. And this is a way that nature protects us, because probably nature, when this was decided by evolution, wanted to protect the woman not getting pregnant too old and not putting at risk her life and the life of her offspring. So what is the biological mechanism? It's to create aneuploidies in the oocytes. So to create abnormal chromosomal number in the cell. This is how it works. And if you see spontaneous fertility, which is this black line, and you see the aneuploidies in the oocyte in different species, including humans and chimpanzee, you see that there is a perfect alignment. So the way that nature protects the woman is putting aneuploidies in two young women and biologically old women, which I would not say that 40 years old, it's an old woman today, but unfortunately, this is what it is from a biological point of view. Now we are in a society where 40 years old, it's a young woman. We are in a society where the expectation of life is double as compared to 200 years ago. We are in a society where there is no desire to have a baby before 30, 35. So we are completely not aligned with the biology. So the biology is the same of 200 years ago, but the desire and the timing to conceive has completely changed. I have a daughter which is 25 and she's really not even thinking about having a baby. And same for my boy. I'm desperate because I want to be grandmother. But this will not happen, I know. It will not happen in the next few years. So why the oocyte is so sensitive? Because meiosis, so the chromosomal segregation in the oocyte, takes years. Everything starts at the fetal ovary, and then it takes between 10 to 50 years old to be ovulated, and then meiosis restart, and then arrest again, waiting for the sperm, and then restarting again. So a biological process that takes years and has two arrests, you can imagine how much is prone to make mistakes. So this is why oocytes are so sensitive, while spermatogenesis is completely different, the meiosis take over altogether, and there is no arrest. So what can we do? Change the society, oblige my daughter to have a baby in the next 5 years? No, we cannot. And probably it's outside of our competence, you know, to decide what society can do to promote the desire. It's not only a question of economical problem, it's a question of desire. It's a beautiful study showing the gap in desire between what we expect from this generation and the real number of babies that we have in our countries. More we are rich, less baby we do. So what can we do? We can, of course, promote awareness to the young generation. This is the most important thing. We can promote social help, and science can help women by preserving this beautiful cell, which is the oocyte, and keep the competence of the oocyte by cryopreserving it. Bam. It has been super difficult. It's quite easy to cryopreserve embryo, but embryo, it's a radio combination of sperm and oocyte, and my daughter has no partner with whom create an embryo. So we wanted to preserve also the autonomy, preserving sperm for men, oocyte for women, but they will decide with whom having a baby in the future. With the introduction of vitrification, which is a different approach for cryopreservation, I will not bother with you, but it is an incredible innovation in the IVF lab that has allowed us to cryopreserve any cell at any stage of development, including the oocyte. And it's quite funny to know that this advancement in cryopreservation has been done because of because of the Italian law that was very restrictive. So we had, for many years in Italy, between 2004 and 2009 in particular, a law that did not allow us to cryopreserve embryo, which was a disaster for the IVF patients, for the infertile population. But it promotes the study of oocyte cryopreservation. So this is why the publication have been done by Italian group, because they deal with a lot of oocyte that could not inseminate by law, and from Spanish group that had another idea, which was to create bank of oocyte for egg donation. So in fact, we were working on oocyte cryopreservation, not for fertility preservation. We were working to better assist our infertile population. But then we extend this accessibility, this technology, to all women, especially oncological women, that want to preserve their fertility. Now, it's beautiful. We can preserve oocyte. We are very efficient doing that. But one oocyte is not one baby. You need a lot of oocyte in IVF to have a baby. And this is one of the best studies showing that with 10 oocyte in a young woman, you have about 60% chance to have a baby in the future. So it's not an insurance. It's just a possibility. And this must be very well explained to patients. But expect too much from this technology. Accessibility is not yet there. France does not allow fertility preservation for social reasons, correct? No. Doesn't change. So for oncological patient, for any patient that has to go gonadotoxic treatment, it is allowed. But as you can see, accessibility is not the same all around the world. My message today is that innovation in IVF has helped to introduce this technology, preserve oocyte for future use in assisted reproductive technology. Is not a guarantee. You just have materials that can be used in the future. And this is very important to explain to a patient that if they want to preserve their fertility, it has to be before 35 years old with a good number of oocyte. And the consultation is very important, and I leave the word to Marc that can continue.
Thank you, Laura. Thank you very much, but the fertility preservation, it's allowed in France for societal indication. Yes. We had the law we had 2 years ago, and now it's allowed between 27 to 37 years old, but not after. It was great.
Yeah,
after many efforts of Rene FRYDMAN and other person, but we
because Rene is really very good. So it's incredible how our technology has to do with laws and ethical issues. So we have to fight against a changing society and also a changing legislation and a lot of ethical issues. So I'm happy that France has followed this innovation, which is so important for many women.
Do you want to add something about other indications?
I will try. Fertility preservation is something very interesting because as a lot of situations, it begins by a medical indication and then is split off for only a desire, a management of the opportunity to have a baby. And these two situations let us go to the importance for the woman to express what she wants and to ever thinking about the doctor. What is the role of the doctor? Are they just pushing the button when a woman asks something and they don't have to say something else? or did they go like a counselor and to distinguish what the positive of this method and the negative of this method can be interpreted. At the beginning, it was a medical indication because it was very important for the woman with a cancer. The treatment for the cancer, as you know, give destruction of the ovary, and many times, and the opportunity to freeze the oocyte, and then to treat the cancer, and then to get the opportunity to have a baby is something, of course, very nice. But when the method developed, it began to have only an indication of a desire. And in fact, in gynecology now, and with all this method, we are on a special point where it is important to listen, to hear what a woman wants, of course, and a couple want. But it is not so easy for the doctor to be a counselor because if he says that it's too early, it's not exactly the time to do that, perhaps she has to wait a little to think because there is no pregnancy at each time, because sometimes there is some risk, of course, and we know that the majority of the women who freeze the oocyte at this time don't use it because they are pregnant naturally or because they don't need it. So important is to give all the possibility to think about this method. We are not in a hurry. It's a majority of the case, we are not in a hurry. And it is important to give the opportunity to the woman to really think about this kind of protection, because it's not 100% sure, because we say that in vitro fertilization, it's a burning stage, and the same will be for the collection of the oocyte. So we have to take the time and to manage all this approach. I think that it will be more and more difficult to go not in the same way that the woman asks you as a doctor to do something. It changed, and I think that it's a pity because normally, and it's the same thing for another situation, for instance, for tubal ligation, you can find in a consultation a young girl who asks you to make a tubal ligation. What are going to do? You decide what is good for her. You decide not to have any question. That's a new way, and especially because we know that the woman show that too many gynecologists were not so kind and so open to listen what exactly are the recommendation or the way of living in this situation. So, I mean, with a technical approach like Laura showed us, that in physiology it is absolutely, you cannot change this evolution, but you can change the ethical approach of that, and it's not so easy, but perhaps it's interesting to have a discussion between us. Thank you.
Thank you, Rene. Laura, can you tell us the ethical aspect about fertility preservation in your center? How can you decide in medical indication and societal indications?
It's a very long question that I'm going to make very short. So first of all, in Italy, the drugs that are very expensive for ovarian stimulation are reimbursed only for medical indication. So we have a priority protocol for medical indication, oncological patient, any patient, endometriosis now, severe endometriosis now enter into this population. So for medical indication, there is no doubt, and I don't think there is some great ethical issue thinking that a woman that is going to lose her potential, very high risk because of gonadotoxic treatment, can access to this treatment. And we have a big discussion about which age you can include in oncological patients. And what we have decided is that it will be the same age that we use to do IVF, because we cannot discriminate a patient that is here to have a baby with a husband or with a male partner, and a woman that is alone but has the same desire and has to go through a treatment that is going to destroy her potential. So we extend the timing over 35 for oncological patients, exactly the same philosophy that we use for IVF patients. When it comes to non-medical indications, so it's only a desire, there is no medical indication, there are some risks, as Professor FRYDMAN was saying. There is a double consultation, psychologist and gynecologist, explaining not only the risk of the treatment of iron stimulation and egg retrieval, not only the real efficiency, because as I said, the expectation is like, I have one egg, I will have one baby, and this has to be destroyed because it's only a biological potential, but it's not an insurance. And the psychologists also follow the patient. We have a team of psychologists and nutritionists because we want also to educate or give the right information about lifestyles. I've seen for cardiologists how much lifestyle is important, the same for fertility. And we don't have any law limitation. So we try to have a real transparent and clear consultation with the patient, but then decides if to do. The very last thing I want to say is true that the return of patient is very, very low. So there are some Nordic studies showing that out of 100 patients cryopreserved oocyte, 5 years ago, it was 10% that were returning. Now it's already 25, 30. It's clear that this is growing because the awareness is changing. And in US, the application of fertility preservation is really very, very high, much higher than in Europe. And I think this is something that will arrive very soon.
Sorry, which protocol do you use in breast cancer, for example?
So I'm not a gynecologist, so, but we always use the letrozole. I cannot answer to this question. I don't think, maybe letrozole is not for all indication. I don't think that we use it for everything, but of course agonist trigger, that's mandatory in case of fertility preservation.
Part of medical indication compared with societal indications in your center?
So in our center, we do very few fertility preservation. So it is estimated that out of 100 patients, 20 are for fertility preservation and 80 are for infertile treatments. In our case, it's less than 10%. So it's very low, and I would say that it's 80% of the 10%, so 8 out of 1,000 is for non-medical indication.
80%
non-medical indication, because patient can access to fertility preservation in public system. We are a private center, so they can access to this treatment in public system. So I think it's a bias of population.
Any question? No? Women health, we speak about women health every time. Now the women health becomes the most important part of the gynecological work. So we spoke about, Laura RIENZI told us about fertility preservation, but women's health will also be concerned with the consequences of menopause and all the pathologies which occur at this time, from gynecological to other manifestation. For gynecological manifestation around the menopause, we'll have a very interesting conference by Professor Attilio DI SPIEZIO SARDO from Naples.
Thanks. Okay.
Attilio, tell us about the innovation in the gynecological surgery in pathology around menopause, if you can. Thank you.
Okay. Good morning to everyone. I come from Naples, so near Rome. So welcome to Italy for all of you who are not Italian. So I didn't prepare my first slide about conflict of interest, but seeing the panel that I have here, my main conflict of interest is that I am the defender of the uterus, because you see, no one mentioned the importance of the organ where then the baby has to grow up. And Professor FRYDMAN said something before, what women want. You remember the movie of Mel Gibson, so the man with the power of reading inside the mind of lady. So lady wants to have baby as soon as possible when they decide. The problem is that Laura told us that now lady comes to you when they are 40, 42. And for many reasons, just because they get married very late, or because they, of course, they study, they did their career for financial reason, because sometimes, you know, to have a baby means cost. And that's why we speak about advanced maternal age. According to the definition, sometimes it's over 35. Some other definition says over 40. And Laura has explained in a very clear way that the potentiality to have a baby are dramatically reduced related to the quality and quantity of the ovocytes. And you see, this is what happened in the world, that the mean age at childbearing dramatically increased from 25 years in 1970 to 30, and even more than 30, I would say, even now in 2024. And you see that we have a lot of pregnancy in women over 40, and the pregnancy of this lady have dramatic complication. So having a baby, it does not mean only to have positive pregnancy test. Then you have to follow this pregnancy in lady over 40. Sometimes we have pregnancy in lady over 50. And we will speak about egg donation. But this is important that we understand, because women come to you, the couple come to you with no awareness about the fertility potentiality and even the problems that they can have. But what does it mean that this postponement of childbearing means that we have a dramatically decrease in the world, mostly in the Western countries, of the total births. And more of these births are now related, they are increasing because of ART, because of course assisted reproductive technology allow the couples, even when the potentiality are very low, to increase the chance of having a pregnancy. And more the therapy and the ART are increasing in terms of success rate, more people go for these IVF protocols in order to try to have a baby. But at the end, this childbearing postponement is the main factor related to the reduction of the total births that we have in the developed countries. But as you have seen before, the importance of embryo is always maximized. And first of all, ladies do not understand that after 35, the quality and quantity of ovocytes is going to decrease. But even from the community of gynecologists and of reproductive medicine, the importance of uterus is even less emphasized. So lady thinks that it's the problem only of the ovary, of the sperm, but then we have the importance of the uterus. And recently, because this is 2026, because the general tendency of modern medicine, not of the expert that you see here, Jean-Marc, Rene, Laura, but of the worldwide community, is that if you put a good embryo, a blastocyst, an aneuploid blastocyst within the uterus, it will determine a pregnancy. It's not real, this statement. And you see here, there are some reasons why an aneuploid blastocyst sometimes does not result in a viable pregnancy and so in a live birth fetus. And you see, because the uterus must be physiologically and anatomically adequate. So we have to put an embryo in a good uterus. Otherwise, we run the risk that the embryo can implant, but we can have a miscarriage, or we can have even severe complication during the pregnancy. And this is important even when you go for egg donation, because sometimes lady comes to you, 46, of course they go for egg donation, but then you check the uterus of this lady and the uterus is not so good. And you have to convince this lady, look, why you didn't remove the myoma, the polyps, or the malformation before? You arrive to me that you are 46, maybe in some centers they do not check the potentiality of the uterus of this lady, but because they think that they use eggs of a very high potentiality women, because of course you choose ovocytes from young lady with very good quality. So it's very frustrating for the doctor to say, look, now you have good embryo, but your uterus is not so good. And what we said before, and it's important key message, that the uterus needs to be at least anatomically adequate. Then we are still far away to understand if it's an anatomically adequate uterus means that is a good functional uterus for having a pregnancy. And there are many factors. Here there are in the panel a lot of ladies I see in the auditorium. So you know that now has been established that if you have polyps, if you have myoma, if you have Mullerian anomalies, all these pathologies can affect spontaneous fertility, but even can affect the pregnancy rate after you do an IVF treatment. So please, the key message is that you should always understand and make understanding couple that also good uterus is mandatory. And the problem is, and with Jean-Marc, that's why we decided about perimenopausal, that when a lady arrives at 40, 43 to you to have a baby, there is also the problem that sometimes she has infertility, but she has also problems of abnormal uterine bleeding. Sometimes the two things go together, so they have problems of menorrhagia, metrorrhagia, so they have very irregular menstrual cycle, and so the ability of the doctors is to understand which are the factors of infertility and the factors of this abnormal bleeding, and sometimes they are the same. But we have also problems of, the ovocytes, and you know that I was very interested to understand that medical reasons are the main driving factors for egg preservation. But now probably it's time that we should always also freeze the uterus of our lady. Of course, it's a very theoretical concept. We cannot freeze the uterus. But we have to understand that in a lady over 40, there is also the risk to have oncological disease. We have a lot of ladies with precancerous lesions like complex hyperplasia with atypia, or even endometrial carcinoma in young age. And that's why the main society, ESHRE, which is the Society of Fertility, ESGO, and also ESGE, have decided to create some guidelines, because it's important even to understand how we have to manage this lady that they have oncological disease of the uterus, but they come to you to have a baby. In the past, we could only answer, we are sorry, we have to remove the uterus because you have a cancer. But now we know that we can save the uterus of this lady, because these guidelines have stated that if you do the stereoscopic treatment plus you put a device releasing hormones inside the uterus, what we used in the past only for contraceptive reasons, so the IUD, the intrauterine device, but in this case it released hormones at high dosage. This device, together with the hysteroscopic treatment that basically is a cleaning of the cavity, it can be safe and effective to preserve the uterus of this lady. Because sometimes I have many couples that they go for egg donation, they come to me to do an hysteroscopy, just an evaluation of the cavity. I do a biopsy, and I find that there is a cancer or a precancerous lesion. And imagine they paid a lot to have to do egg donation. In Italy, more or less, is 10,000 euro. The couple pays to start the stimulation of the donor. Then they come to me, I do hysteroscopy, I say, look, you have a cancer of the uterus, so you cannot put embryo in a uterus with a cancer. And then you have to start a protocol to save this uterus. And that's why we are in 2024, in the moment that we can also give the opportunity to lady with cancer to have a pregnancy, because we have these guidelines that also create a little bit of reassurance in the worldwide community to deal with this lady. And in conclusion, I think that Laura said something important, fertility awareness. I think that this is the main important problems that women, probably she said, so her daughter has probably the mom, which is, I always define as the queen of infertility. But still her daughter does not think about egg preservation, of having a pregnancy before 35. Because now the priority of women are others. It's not only as in the past to have a baby. And so it's important that we as experts, we should maximize the couple's potential. So it's important that we always check all the parameters in order to have a pregnancy. So the male, the women, but the women, it's not only ovary, it's also the uterus. And that's why the crazy idea that we had, and thanks even to Jean-Marc and Laura that were great speaker in our Congress, we decided to create, to arrange a Congress about that we called HARTUS, that is the acronym for Hysteroscopy, Assisted Reproductive Technology, Ultrasonography. Because it's important that we specialists of different fields, we have to speak one each other. Because when couple comes to us, it's not only a matter of one factors, but we have to evaluate all the factors of infertility. And so we should move from silos to multi-specialist working group, and more specifically related to my field, we still have to understand which is the best timing, the best technique in order to evaluate the uterine factors. But in order to conclude this, I think, round table, from my point of view, what is important is fertility awareness should be global, should be quick as possible, so ladies should understand that after 35, the quality of the ovocytes decrease, but even the quality of the uterus decrease, because we have seen that there is an increase of pathology that can affect infertility. And for the uterus is always even worse, because there are also oncological pathologies that can happen within the uterus of this lady. Thank you.
Thank you, Attilio, for this is a very interesting speech. Laura is the princess of infertility. You are, and you are the prince of reproductive surgery and hysteroscopy. I see, and I saw that in Roma last month. It was very, very interesting to consider the mini-invasive surgery, the mini-invasive reproductive surgery, to improve the results and to help Laura in her work. So this is for mini-invasive surgery for reproductive medicine, but what about mini-invasive surgery for pre-invasive cancer, pre-lesion cancer, endometer, and the role of hysteroscopy in the management of these lesions?
So I always say that, just because I think that here you are not all gynecologists, probably the minority. Hysteroscopy is derived from Greek words. Hysteros is uterus, scopeo to see. If I switch off the light from this room and I say to you, please remove all the chairs from this room, probably we will remain some chairs inside the room because it's a blind technique. Think that all doctors that still rely their activity on blind technique like dilatation and curettage, like Pipelle, like curette, in the world people still base the evaluation of the uterus with blind technique. I always do the comparison with ladies, just like you drive the car in a gallery with switch off light. It's unbelievable. Hysteroscopy means that you just put the camera inside the uterus and at least you see what is inside the cavity. And if I have to take a biopsy, I can do in a precise way because I see which chair I want to remove from this room. And now reproductive surgery means that you apply the concept of minimal invasive surgery because we don't want to create any damage to the uterus, so we want to get very easily inside the uterus of this lady, and we do in outpatient setting. Means 1 minute, no analgesia, no anesthesia, the lady comes, and after transvaginal sonography, you do an easy and quick hysteroscopy, and just to check if the uterus, the cavity where you have to put the embryo, is normal or abnormal. And if abnormal, as Jean-Marc said, you can even treat by hysteroscopy. So if you find the polyp, if you find something inside the cavity, with miniaturized instruments, we think about less than 2 millimeter, you can do surgery within the uterus.
Can I ask you a question?
Yeah, of course.
If you have a woman who come to see you, she's 35, 36, so you want to have some indication on her uterus. What kind of examination will you propose between ultrasound, between IFOSI, between hysteroscopy, between IRM?
You
say that you want to know what is the uterus situation of this woman. So what do you propose?
Yep, thanks for the question. So in order to evaluate the female genital tract, we always do 2D, 3D sonography because now all the sonographic machines have also 3D that improves the accuracy of the technique. And we always do an hysteroscopy because we strongly believe that some pathology cannot be diagnosed by sonography. And so mostly what we call subtle lesion cannot be seen. And we use as baseline investigation, but in order also to reduce the time to pregnancy, because sometimes when the couple comes to you to have a pregnancy for IVF, you do hysteroscopy as baseline, you find that there is something inside the uterus, and it happened to everyone, you remove the polyp, you treat the endometritis, and the pregnancy arrives even without the need for IVF. And so there is a 15–20% of couples that they get pregnant as soon as they start to put themselves in the waiting list for IVF. And then I believe that if the lady has to undergo an IVF, I repeat an hysteroscopy if a long time passed. More or less in our center we have 1 year of waiting list. 1 to 2 months before the transfer of the embryo, we repeat an hysteroscopy because we think that some transient lesions can be seen in this phase. I understand that sometimes in some country, probably in France, in the North Europe, hysteroscopy is still perceived as an invasive, painful, and not cost-effective technique, but in normal hands, I cannot say in expert hands, is a technique that in less than 1 minute, with reasonable cost, it allows you at least that to check that this cavity is negative. So negative means with no pathology.
And more and more without any general anesthesia.
Of course.
Even for surgery by hysteroscopy. Thank you very much, Attilio. The ovaries and the uterus are not the only organ which interested by the menopause. Other manifestation and other consequences of menopause can be seen. Now we will see the other consequences of the menopause with Dr. Michèle VERSCHOORE, which Michèle VERSCHOORE, she's a dermatologist, skin scientific expert, former medical director of L'Oréal. Dr. VERSCHOORE, it's yours.
But today, thank you for the invitation too. But today I'm not here as a dermatologist, as a skin science expert. I'm more on my other hat with a group of women in Paris. We have created the French chapter of an association called the International Women Forum, which was created in the US 20 years ago. And among these female leaders, we have discovered and understood that women's health cannot be only summarized to fertility, reproduction. And I would like to give you some figures in this next 4 or 5 minutes about the non-visible part of the iceberg, because the iceberg is what we have seen today with gynecology number and reproduction numbers. But there are a very rapid shift in general diseases specifically for women and specifically linked to the change of lifestyle. There is a misconception that first that the women are in better health than men because of the gap of life expectancy, which is about 6-7 years depending on the countries. But recently, what has been really very well understood is this increase in life expectancy has to be covered by the quality of life in these 6-7 years. And today we speak about life expectancy in good health. And for women, it's not so good because there is a gap, a major difference between life expectancy in good health for men and for women, which is increasing and increasing every year. So these differences have to be understood not only about the biology, because we know that there is a sex differences, genetic differences in biology for cells and cellular metabolism, but we have also to understand what makes these differences in terms of society evolutions and cultural aspects. In fact, 95% of women's health is not dealing with reproduction. And the first cause of mortality of women in the world is what we have seen this morning with cardiologists, is heart diseases. And it's very important that for women, the lifestyle diseases like metabolic syndromes and heart diseases are well understood with their own symptoms and specificities in order to allow early diagnosis specifically for men, cardiologic diseases, for women, cardiologic diseases. 80% of women over 45 years have at least 2 symptoms of risk factors for cardiac diseases, which is huge and which is also increasing every year. Cancer in women, gynecologic cancers are the second causes of mortality in women. The third being depression and suicides. And the fourth reason of death in women are the consequences of domestic violences, which is also very striking as a number. All these differences in men and women in diseases other than gynecologic diseases starts quite early in life. For example, the diagnosis of autism in little girls is delayed by 3-4 years compared to boys. Why so? Because the teaching of autism symptoms in medical studies doesn't cover the specific symptoms of autism in little girls. Having said that, what's happening is because the diagnosis is delayed, the prognosis also is delayed and is less good because of the symptoms not early recognized in young girls' autism. Then the treatment will be less productive and less effective. Another side, another disease, other diseases where we have differences between men and women is the cancer. We know that the cancer risk is about to be stable. In some cancer is decreasing for men, but we see today a major increase in cancer for women, especially liver cancer and lung cancers. And obviously, this is a consequence of the changes of lifestyles, where women are more exposed to alcohol, to tobacco. There is a study showing that this risk, in European study, showing that this risk of cancer in men is decreasing by 1.4 in men, all types of cancer confounded, but it is increasing by 0.7% every year in women, which is also a striking number. Another consideration where women are affected more than men in general diseases is in chronic obstructive pulmonary diseases, in COPD. And why so? Women are more affected by these diseases because they are more exposed in the professional environment to the detergents, to the antiseptics, because more women are working in professional cleaning industry. And that's why there is a constant increase of COPD in women, whereas it is decreasing in men. And to complete this overview of recent numbers regarding depression, depression affects about 13% of women, whereas it's about 6% of men. And this has been also increased during the COVID crisis because of remote work. There is an additional load of work for women, and this has also given an increase of depression in women. And we know also, and especially as dermatologists, that there is for autoimmune diseases a greater sensitivity to autoimmune disease in women than in men. So having said that, which is a picture which is not so positive and so a bit somber, there should be some some way of improving the situation. For example, in France, there is an acceleration of works being done on the sex specificities in biology for female cells and male cells in order to early diagnose and understand very early what are the metabolic differences between men and women. We cannot consider that women are just a small weight men, and also in clinical research it's very important that clinical research also covers the female specificities and include females at the same ratio as they are included in male. And then clinical research works on men are not extrapolated to women because it will bias the research. And also, we all have been in medical school. We had the profiles of what are the cardiac failure risk. For example, with the idea that it only covers, it attaches men with high activity, with responsibilities, traveling a lot, drinking a lot, etc. But we have also today to include that the fast evolution of the society in the last 30 years also have touched women, and we should change the profile of heart failure diseases for female, where the symptoms are specific and should be also a good point to be trained for training in medical studies for the medical students. And also at school, there is a prevention to be given for young girls and young boys. Why? Because the sensitivity of a female body, young female body and young male body is not the same. And for example, the greater sensitivity of young girls to alcohol and tobacco also has to be trained at schools, because we see that younger and younger women, teenagers today, are exposed to high doses of alcohol and to extreme smoking. And at this age, there should be campaign in schools to prevent the high risk of lung cancer and liver cancer in women. And I can also talk to Philippe, Tous de Blazy, I've seen just here. There should be also some public health campaigns directed on this awareness to let women know what are their specific risks in their own health. So I thank you for giving me the opportunity to speak about this other part of women's health, and I'm ready to answer to any question.
Thank you. Thank you very much, Dr. Michèle VERSCHOORE. As a skin scientific expert, do you think that hormonal treatment improves the skin quality?
Yes, it has been shown that substitution treatment, HRT, is very important to maintain skin quality and density. And this is also linked to the cognitive health. And we know that brain and skin are the same embryological origin. And so maintenance of a good level of hormones with these treatments has been shown to maintain the quality of skin. But what we say, I think there are many gynecologists and endocrinologists here, this should respond just to the need of the woman and not be a treatment given to all women. If women have symptoms like flushes or fatigue or insomnia, etc., this treatment should be given, because in addition, this is a symptom that there is a need of hormones. And then in this case, we will see that there is improvement of skin quality.
Thank you.
I remember that at the beginning of my training program, I was in the menopausal group, and we did some study about the importance of HRT for skin disease. We showed that there was an improvement, I don't remember, but of the different types of collagen within the skin. And we also showed that the HRT can improve some symptoms of the eyes, of the smell. So because in menopause age there is also a dramatic decrease of all the 5 sense potentialities, and that the skin should improve with HRT. But of course I agree with you that it should be a counseling, 360-degree counseling to decide to give or not hormones to this lady.
Yeah, it should not be systematic. We should follow the symptoms of each lady. Yeah.
So, thank you very much. Now it is time to break coffee. Coffee break? Time.